Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I'm just going to talk about some cases, some people that I'm seeing, and also about functional leg length discrepancy. I may have mentioned it before in the context of working on the QL, but I just wanted to mention that it's something that is not uncommon, and I want to just talk about how I address it. You will read that the functional leg length discrepancy can come from the adductors, and I believe functionally it makes sense if the adductors on, let's say, the right side is the leg that's too short. The adductors on the inside could be hiking the hip a bit, but most of the time it's going to come from the QL on the side that's too short, because the QL can hike the hip. So when the QL is short, it's lifting the hip a little bit and making one leg act like it's too short. That person ends up standing on their longer leg and just sort of they stand on the short leg and they keep their longer leg knee bent. So if the right leg is a little shorter than the left functionally, they'll stand on the right leg and then just kind of keep the left knee bent or crossed over their ankle while they're standing, things like that. It becomes like a normal thing for them to feel even. But it can be addressed and corrected very quickly, usually 1 or 2 sessions. But you need to know how to dry needle the quadratus lumborum. You're not going to find somebody with a functional leg length discrepancy where the muscle is just a little too tight or a little hypertonic just from, overuse or something like that. This is going to be a situation where it's accumulated so much tight bands that the electric stimulation is not going to release enough to see a return to function or normal leg length. So you'll end up palpating the QL from way down by the pelvis, which is where you usually find the most fibrotic area. Or work your way up to the middle area that's like midway between the ribs and the pelvis, and sometimes a little bit below the 12th rib. But usually you're going to get the best release in that middle section and the lower section. The lower section, by the way, is also the section that I find will be an entrapment zone for the superior cluneal nerve, which we've talked about before. So you will see that area being the tightest for somebody like this with a hip hike or a functional leg length discrepancy. I tend to needle it from the lateral border of the QL, angling toward the spinous process. Of course, not trying to hit the spinous process, but that's the angle. And of course, I'm not going to try to teach you how to dry needle on a podcast, and I prefer, if you've never done it, that you learn it in person. But there are people out there who already dry needle. So I'm talking to you when I'm talking a little bit more specifically about where I like to needle. You can start at the edge of the QL and work your way toward the middle, palpating, getting some good twitches, and then feeling it again and seeing how it is. And, it's kind of a thick muscle. So sometimes you're in the more posterior part of the QL, and then you need to kind of work a little deeper, always being safe, not going into peritoneal cavity, not doing anything that's uncomfortable for the patient, always getting feedback. But you can pretty quickly get really good relief and release of the QL. And then I would recommend, just do some gentle stretching to get the QL back to normal. Um, I've talked about some foot neuropathy patients. I have two patients that are doing really, really well after very few treatments. I think 4 or 5 treatments, both of them. Both of them over 70. One is 90, what do you say, 89? He's turning 90 soon. And he was a little tougher case than the woman that I'm seeing. I just saw her, and she's almost back to normal for her foot neuropathy. She on her right leg, she had numbness on the front of the leg and at the top of the foot, and then numbness on the bottom of the foot. And on the left side, she just had numbness on the bottom of the foot. The right numbness on the top of the foot seemed to have happened after a knee replacement surgery. So she still has some numbness in the patellar tendon area, which I don't think we're ever going to get back. I don't think we're going to get that sensation back. That was post-surgical. But the superficial peroneal nerve seems to have been the issue on the right leg, and that resolved really quickly. So she's doing really well with that. The plantar surface numbness, the right side resolved quicker than the left side. The left side still had some lateral foot numbness and just under the pinky toe. So, and she, I think a couple sessions ago, she was saying the balls of her feet were still numb, but after treating the flexor digitorum brevis with motor point electric stim, she got that back. So I think that was more ischemic than it was plantar nerve entrapment. And then lateral part of the foot is coming back now. So she's almost to 100%. I'm really happy about that. I think we're talking 3 to 5 visits, probably 5, counting this week. And then the man that I'm talking about that's 89, I was a little worried that I might not get as good of a result with him because he could feel a lot of his foot. I think after the 3rd session, he said he still has numbness in his heels. And that made him feel like his problem had not gotten better at all. But if I would feel and ask him if he could feel my fingers, he was actually ticklish. He could actually feel a lot in the arch of the foot and the ball of the foot and the top of the feet. The tops were numb until after the 1st session. Then that was resolved. And then I treated as superficial peroneal nerve, extensor digitorum longus and peroneus brevis. Probably, I don't think that on him I needed to do extensor digitorum brevis because he didn't have pain in front of the lateral malleolus. But that's another option for that entrapment. He was not feeling his heels, so I added quadratus plantae because that can also affect the calcaneal nerve branch of the plantar nerves. So I treated that last time. I saw him this week, and he said, he said there are times that I feel completely back to normal. And then maybe towards the end of the day, it'll get worse and I'll have numbness again. But it does seem to be progressing. He said to his wife, I think this is going to get better. It's definitely getting better. Now, I asked, he is taking a beetroot supplement. I asked them to take a beetroot supplement if there's no contraindications for whatever their medications are or any issues with low blood pressure or anything like that. And he's doing that, and I think that's helping his circulation enough that this has been improving. But I think that his arches are just a little too low, not being supported. I asked him to look into getting better shoes, and he said, "Oh, I just bought new shoes." I said, "No, I'm not saying you don't have nice shoes. I'm saying your shoes don't look like they're giving much arch support." And I really think you need it. And it would be better if you get a foot scan so it's tailored to you and they're not too high or too low. But my suspicion is that he has good days or good hours. And then because of overpronation, he's getting that tarsal tunnel entrapment of the plantar nerves. And then he has numbness again. I think his ischemia has improved, and he's getting good circulation, and he's having a lot more sensation. But I think the reason that it won't stay is because of his shoes. So I'm hopeful he's going to go get it. He said he's going to go to a place here in Buffalo that does um, they do orthotics, and I think insoles. So that are like cheaper insoles, not just orthotics. Orthotics can be really expensive, but it's they're experts. I think they'll help him figure out what he needs. Um, so that's those patients. I have another patient. I'm seeing some college athletes, some college football players. Um, I love working. I love when I'm working on on the athletes because they're they're an easy part of my day. You know, the working on young healthy people is like it's textbook. You know, everything works the way you want it to. Everything works the way you expect it to. The tough, challenging cases are the ones where they're they're over 70, they can't stand up straight, their whole spine has been fused over the course of 3 surgeries. The spinal stimulator no longer works, but she doesn't want to have it taken out because she doesn't want another surgery. But the spinal stimulator takes up the whole space between the 12th rib and the pelvis on the left side, making it really hard to inch a needle into the quadratus lumborum. Um, I mean, neuropathies in the feet, so she can't like putting on a sock hurts. Just the brushing of fabric against her low leg hurts. The whole rib area in the back is sensitive. Just clothing hurts her. The, those are the tough cases. That's the stuff that's always a bit of a challenge. But I'm always happy to see them feel better at the end of a session. And the woman I'm talking about, I just saw twice. I saw her for her second session this week, and she really did feel a lot better after treatment. But I have more to do for the neuropathies. I was able to kind of tap in a needle in the peroneus brevis and the extensor digitorum longus, even though touching her leg hurt. I was able to just kind of put the needle in without pushing too much on her legs. And I'm hopeful that we can decrease that neuropathy, that hypersensitization. Um, and what else? I have a headache patient, a migraine patient who was doing really, really well for months with no migraines. And then all of a sudden he went on a cruise with his family and he was suddenly having migraines every day. And he came back and I saw him and he had this, I mean, it was so much occipital pain just touching the area. The rectus capitis posterior major and the obliquus capitis inferior were really sensitized on the left side, where his headaches usually originate. And I got it calmed down, but then I guess a couple of weeks later he was at the headache center in their emergency room getting an IV because he was nauseated and just felt really horrible. And so I fit him in. I saw him on a Saturday. I don't usually work on the weekends, but he was so miserable. He was like basically texting me from their emergency care. And he said, "Can you see me? I'm just hoping maybe you can get me out of this pain. I'm in so much pain." So I saw him and his left rectus capitis posterior major was like stuck. It was so firm, and I released it and he could feel some improvement. I think he's doing better. The conclusion we came to together was that he's letting himself get dehydrated when he is not on his normal schedule. He's not hydrating well. He says sometimes he'll go the whole day without eating or drinking anything. So I think a lot of his migraines were being driven by the dehydration, because I think that would explain why he was doing really well. And then when he went on vacation, he was off of his routine. He just wasn't paying attention to hydration. So I'm hopeful we'll get him back on track. But I wanted to share that in case you're talking to a migraine patient where you think that maybe dehydration is the key. What else am I working on? I see I've got a lateral femoral cutaneous nerve entrapment patient. He's doing better. I saw him twice. I saw him his second visit this week. He has less pain, but some numbness still on his quad. Um, I'm working with, what am I working on? Another volleyball player. Uh, Lots of low leg stuff for the athletes, like Achilles stuff. And um, yeah, so I was talking to the football player for his Achilles pain, and I was saying, isn't it interesting that I'm working on your psoas and hip flexors for your Achilles? But my thinking is based on you know his history of hip labral tear surgeries and things like that, that a lot of his Achilles is problem is coming from hips. I think that the anterior pelvic tilt is shutting off his glutes, and therefore his hamstrings and calves are working harder to propel him than they should have to. That I think if we get his pelvic tilt corrected, work on the hip flexors, TFL, glute min, glute med, um, rectus femoris, psoas, get all of that firing better, more flexible, it will give him more strength in his glutes, which will mean his hamstrings won't have to work as hard, which means his calves won't have to work so hard to propel him when he's running. That's my theory. I think that's sound. And so yeah, I was talking to him about interesting that we're working on his hips to help his Achilles, but I think it's essential. He had really restricted hip on the surgery on the hip that had been fixed 3 years ago. The other hip was fixed in the past few months, maybe in January or something. All right, so 7 months or whatever, 8 months. So anyway, but I think I think it's really going to help him. And I said, and besides, we need to do this just for your quality of life, not just so you can play in the game next week and feel great, but just like quality of life, your hips need to be better. So we worked a lot on like TFL, glute min. I think for labral stuff, you'll see a lot of glute min issues because of the way that it that second tendon of the glute min will go into the front of the joint capsule. I think that part of that stabilization, and the psoas too, the psoas being like lesser trochanter, I think a lot of that hip stabilization issue caused by a labral tear is going to cause tension in the TFL, glute min, psoas. So that you'll see that. I think I see that a lot actually. Piriformis also. So so that's those patients. Trying to think if there's anything else that was interesting this week as far as tough cases. I have a Cauda Equina case. I didn't really know much about it. I saw the diagnosis from the doctors. He had a lot of, I think originally from the injury, he had lumbar fusion, and after that he had a lot of numbness and rectal pain and problems urinating. Couldn't empty, or would feel urgency and then couldn't go. The urgency, he said, was just fake. It really didn't need. He really didn't need to go, but he felt like he needed to go. And he said ever since I started treating him, we had our third treatment this week. He said ever since then it's gotten a lot better. I'm working on deep rotators. I'm working on the lumbar area. I'm working on everything that seems neuropathic. He had a lot of superficial peroneal nerve symptoms, some pain, tingling, numbness in the low legs, in the front of the leg. Working on that. I think that seems to have calmed down as well. The sciatic stuff is better. He still gets a lot of low back pain. He basically came in at his on the VAS scale of pain. He was like at a 7 on a regular basis. Like that was like his normal. So I think he's doing better as far as that goes, but it's up and down. It's not been a straight ramp up. He'll have a lot of improvement, and then he'll have a setback, and then he'll have some improvement, setback. So we're going to see. It's a tough case. I told him I don't think this is like a 3-visit thing. It's going to be some work, but it's the first thing that's giving him any relief and any hope, because pretty much medication is not cutting it. So that's an interesting case. I worked on a runner with some left SI joint pain chronically. That seems to be doing much better. Mostly working on anterior pelvic tilt and the deep rotators and glute medius, things like that. Who else am I seeing? Well, that's probably enough. That's kind of like rundown of my week. A lot of my week is working on a lot of the tougher sort of nerve stuff. I seem to now be getting a lot more of the tough nerve cases. I was referred a patient that I'm seeing next week, that a senior again who seems to have a lot of ilioinguinal, iliohypogastric pain that wraps around the side of her abdomen area, burning, goes into the groin. Only one-sided, makes it difficult for her to rotate her torso. So I'm going to be approaching that with palpation to see if I can confirm it, pushing on abdominal areas, pushing into the front rectus abdominal border area to see if there's some pain and entrapment there. That's usually an entrapment zone. A little bit medial to the ASIS is another area you'll feel on the way to the aponeurosis of the obliques. That area can have some entrapment. It could also come off of the lumbar area around T12L1. There could be some sensitivity there if that's where it's being entrapped. And I would also treat the QL because it's a relevant innervation for the QL. So we'll be looking at the QL as well. It innervates the transverse abdominals. So, of course, we'll be treating them, if for no other reason, for like neuromodulatory purposes. But the entrapment usually happens between the obliques and the transverse abdominals. And like I said, close to the rectus border for the abs. So that's where we're going to go for her first visit and see how it goes. I'm thinking I may use some soft tissue work like IASTM on the abdominal fascia as well to see if that can help free up the nerves, let the fascia pass over them easier. We'll see. But this is like all post, I think, lumbar fusion, either laminectomy or fusion. I don't remember. We were talking on the phone a couple weeks ago when I booked this appointment for her, but I'm getting a lot more of these tougher cases. And of course, the older the patient is, the little trickier it is. But, when you can do really good things for the seniors, you know that your technique and your assessment is much, much better. Those were always the toughest cases for me. And maybe 5 or 6 years ago, I probably wasn't or wouldn't be getting such good results because they are such tough patients in many ways. They don't heal as fast as you might like, and they have multiple issues, and they've had multiple surgeries, and sometimes you push your fingers on their back and you're not quite sure if you're pushing on the metal cage that has been placed in their lumbar area or if the muscles are really that hard. And it can be a little bit of both. But it's insane. It's not what it's like to treat a college football player. Let's just say that. So, so that was my week. I guess the key I wanted to get across was the hip hike from the QL. That was the thing I kind of initially thought I was going to talk about. So pay attention to that. And, take a course where you can learn some hands on dry needling for the QL, because it's one of the most common issues that I have to dry needle, and you want to do it safely. So that's it for this week. Have a great week and take care.